Very good. Good evening. We're going to get started with today's cardiology grand rounds. As you would know that we are celebrating a new renewed profile for the cardiology grand rounds. We are examining the future of cardiology in a series called as Back to the Future of Cardiology, where we are able to bring in stalwarts and eminent speakers from both academia and industry to examine what the future of cardiology is going to be. And here on the screen is the website link for the new division of cardiology grand rounds platform, where you can go and have a look at the previous grand round series and partake with the educational offering that the division intends to offer. For the grand round series, as you would know, we are providing the CME credits. So for this particular specific CME credit for this grand round, today's grand round, please go ahead and text the number 12445 to the number 888-816-4893. Please go ahead so that you can register into the CME crediting messaging system. And it should be an SMS message. And you need to have an active profile in the Cloud CME. Please ensure that you have an active profile in the Cloud CME. We have also offered, along with the CME credits, an opportunity for physicians to get a maintenance of certification points. For the maintenance of certification points, you'll have to complete the step 1. And there is a link here which will be provided to you in the chat box. You'll have to go to this link and type the code future03, future03. There will be a specific question that you will have to answer. And if you answer it correctly, you get the credit. But it's very important that physicians who are intending to get the MOC point have an active profile in the Cloud CME where their birth date and also their the specific licensure and ACGME profile is completely verified. So if you have all this thing verified, then you will be able to directly get the MOC point, which will be reported back into your own personal websites. With these points, I'm really honored and delighted today to bring forth our grand rounds for today. And our guest speaker for today is a great mentor and a person whom we have revered for years together. I specifically have enjoyed being with him and learning from him, Dr. Jagat Narula. Dr. Jagat Narula is the Phillips J. and Harriet L. Goodhart Chair of Cardiology, Chief of Division of Cardiology at Mount Sinai, St. Luke's Hospital, Professor of Medicine and Radiology for the Icahn School of Medicine at Mount Sinai. He's also the Associate Dean for the Arnold Institute of Global Health at Mount Sinai and the Director of the Cardiovascular Imaging Program for the Mount Sinai Health System. Now, a lot of people would not know, but I have a specific relationship that I would like to disclose. So Dr. Narula is a legend in cardiology, and I came to know about him, but never met him when I was at All India Institute of Medical Sciences. He did a fellowship in cardiology at All India Institute of Medical Sciences in New Delhi, which is the premier institute of the country, and then went on to pursue his PhD in cardiovascular immunology and came to Mass General Hospital in Boston, where he further pursued fellowship. So we always followed him in our discussions when we were when All India Institute of Medical Sciences. I remember having read his articles that were published in circulation on rheumatic heart disease when I was a fellow. but I did not know that I'll get a chance to meet him when he moved to Philadelphia as the director of cardiovascular research at the Hahnemann University Hospital. In 2001, I had an opportunity to meet him there. And he was also directing the heart failure and the transplantation program, and also the Thomas Vischer Professor of Medicine and Chief of the Division of Cardiology with Vice Chairman position for the Department of Medicine. So I met him briefly and got to know him. And then I pursued my fellowship and research at Mayo Clinic. But I think he kept some form of connection with me. He then on became associate editor at JACC. And when I submitted some of my work to JACC, I think we reconnected back. And I have to admit here that what I was boldly doing at that time was something that I was proposing in the same field that he was very interested in. And he was working on a theory of myocardial function that was proposed at that time. And he took keen interest. And I still remember that as an editor of a journal, he wanted certain clarification of the theories that I was proposing. And he called me directly and pursued my work, gave me directions. And till the time he was not completely settled with the whole idea, he made it sure that I provided convincing evidence. And when I then submitted the paper, that's the time the paper got accepted. So I still recollect those days when, as an editor of a journal, he calls me and engages me and brings the best out of me. And I cannot forget those formative years of my life where he really contributed to the science and invigorated me as a physician scientist. In 2003, subsequently, he had moved on to California Irvine School of Medicine. He invited me to give a grand rounds. He was the professor of medicine, and he was very much involved in mentoring young faculty, and he gave me an open invitation to join him. So that's where my journey began, to work with him. And in 2011, he moved to New York City as the Philip J. Harriet Goodhart Chair and in Mount Sinai, and I landed up with him. And having been with him has been an experience any fellow or any young faculty would love to have. Despite his extensive background, he has been extremely approachable. And in fact, that specific aspect of his ability to relate to people at any level makes him a role model. In fact, ACC went on to give him the Legend of Cardiology designation in 2012. He has an extensive CV. If someone wants to pursue, there are some forms of them available still on websites, and often I come across them. This is probably must have come across his CV in 2012 and 16. I've seen the last time he had 1,000+ publications. They're about, it's almost like a book. It's about 200+ pages, over 1,000 publication, and over 30 books or journal supplements that he has edited. And he has extremely and very profoundly contributed to the science and influenced the science of modern cardiology. He became the editor-in-chief of a Journal of American College of Cardiology, Cardiovascular Imaging in 2007, and then also became the editor-in-chief of Global Heart and executive editor of Journal of American College of Cardiology. He's also been the founding editor for the heart failure clinics of North America. And you can just imagine through these contributions on a day-to-day basis, how much he influences the field of cardiology worldwide. His translational work, I think almost every aspect of cardiology he has impacted, but specifically, he has been very keen in imaging with the strategies to identify patients, and he's going to give a talk to us on vulnerable plaque and myocardial infarction, and has a focus on a prevention recently. among most of his most important works and contribution is this description on a phenomenon of heart muscle suicide called as apoptosis and vulnerability of atherosclerotic plaque. Most importantly, he has won almost every single award that are given by the ACC Awards Committee, and of course he's a legend, not only among the cardiology fraternity, but it's important that the fellows internationally, particularly the Japanese fellows, have actually created a fan jam organization that's a fellows associated with Narula Lab from Japan, and they do an annual meeting every time he visits Japan. So these are his contributions. With that note, I want to bring in Dr. Narula. Thank you for joining us. It's been a great pleasure to have you with us. And we will also have an introduction to our other panelists. And the other two panelists will be complementing his work. And we will be able to bring in a panel discussion after he gives his presentation. First panelist is Dr. Dinesh Singhal. Interestingly, the 6-degree separation is something that is going to get defined in this particular Grand Rounds meeting. Dr. Singhal is also from All India Institute of Medical Sciences. After illustrious medical school and gold medalist career, he moved on to pursue cardiology in the US. And he has kept an extensive interest in clinical research related to diabetes and cardiovascular prevention programs. He's affiliated, despite his work in the outreach and the community settings, with teaching hospitals in Philadelphia, St. Peter's University Hospital, and also at Robert Wood Johnson University Hospital with us. He's an entrepreneur, and one of his activity, which I came across to know, was he hosts a radio show where he tells about management of cardiovascular and metabolic disorders. And he has been keen on emphasizing prevention, wellness, research, and education. So welcome, Dr. Singhal. And our third panelist for today would be Dr. Tudor Voginescu. Dr. Voginescu is Associate Professor of Medicine and the Medical Director of the Cardiac Catheterization Lab at Robert Wood Johnson University Hospital. He's one of the most experienced and sought-after operator for coronary complex interventions, and his dedication to the program is known for the long hours that he spends in the lab, also helping with our community fraternity to be successful in the coronary program. He also has a small connection here. He did go to Mount Sinai when he came from Germany and spent a year. So there is a connection here in the circle. So before he assumed his cardiovascular disease fellowship and then went on to pursue his career with us. With that note, now I would invite Dr. Narula to share his screen and maybe give his presentation. Dr. Narula. Joseph, can you make Dr. Narula the primary presenter?
Thank you very much, Dr. Sengupta, or actually Parthoji as I call him. G, as you know, is, or some of you may know, is a very, it's something like when you call anybody with respect, you add the suffix like G, quite like what we do as san in Japanese and some of the other ways of doing it. So it has indeed been a pleasure to be associated with Dr. Sengupta for all these long years, something like from 2003, so almost 17, 18 years now. And I've been truly proud of what Dr. Sengupta has achieved since coming from India, and the way he has shown in the field of cardiovascular imaging specifically, and now the artificial intelligence that he's working on, a pioneer in the field today. And so I'm truly honored, and it's truly a privilege to be speaking at a place where I'm sure that is poised to make a big leap and a big jump to become something they have always aspired for, but has not been able to do so. So good luck, Parthoji, and I'm really happy to be here. So the topic, as you saw, was going from a very basic concept to treating the patients coming to the bedside, and then trying to see whether we can go to the population. So targeting plaques, treating patients, or tuning the population. So let's go back to some of the historical data here. This is the European Coronary Artery Surgery group, and which had demonstrated and compared in some of the early randomized trials, compared the optimal medical therapy with the surgical revascularization. And they had demonstrated that the surgical revascularization was significantly superior to the medical therapy, and it stayed so for a long period of time. And not only that, there were significantly larger number of people who were free of angina, and also that they maintained a significantly superior functional capacity over a period of time. Why did it really demonstrate something that was so significantly different between surgery and the medical therapy? Was it that we did not have the optimal medical therapy at that point in time? Or is it that the lesions were different, specifically since it was a pre-statin era? Is there a possibility that the plaques that we saw at that time were somewhat different? And that's what we have really seen in the treatise of Dr. Michael Davies, that these plaques probably were the so-called high-risk plaques or vulnerable plaques, specifically as there were not many drugs available to us which had controlled the LDL receptors or were able to control other risk factors for us. The risk factors were prevalent at that time. And as you can see here, that the plaques, which are so-called high-risk plaques or vulnerable plaques, they have a very distinct histomorphological characteristics. For example, in this particular case, you would see that these plaques have large or huge necrotic cores. They are covered by a very thin fibrous cap. They are positively remodeled, because once the fat starts to collect in these plaques, first there is an outward expansion of these plaques, and only until about 40 to 60% of the cross-sectional vascular area, which is occupied by the plaque, only after that it starts to impinge on the lumen. And once that happens, then it comes with a vengeance. There is a rapid progression of the luminal stenosis thereafter. Here you would see that there is a very thin fibrous cap of the plaque, which is a high-risk plaque, and upon staining with the CD68, which stains the macrophages, you can see that the fibrous cap is significantly inflamed. Now, on the next panel, here you would see the figures, which are the representation of the optical coherence tomography. And the reason for showing this methodology here is because that is the only methodology that we have an access to which demonstrate the fibrous cap thickness, because the resolution of this imaging technology is about 10 to 15 micron. So this is the plaque, which is the high-risk plaque or vulnerable plaque, plaque which has large necrotic core, plaque which has positive remodeling, plaque which has very thin fibrous cap, and that is significantly inflamed. Since there is a thin fibrous cap, any hemodynamic perturbation can lead to the plaque rupture. And here you would see that the plaque has ruptured at this site. You can clearly see that the necrotic core probably has sloughed off, and thin fibrous cap can be seen here. And if you stain it, it would be positive for the macrophage infiltration. So this is the ex vivo optical coherence tomography that has been undertaken. So the large necrotic cores, the thin fibrous cap, inflamed and positively remodeled, that is your vulnerable plaque. So was this something that will continue to happen? The case was not such when we looked at the COURAGE trial. As you would see in the COURAGE trial, that there was no difference in revascularization almost at the same follow-up or with the optimal medical therapy. And it was seen as a win for the optimal medical therapy, that it can influence the outcome as much as the revascularization would do. So is it really a win for the optimal medical therapy? But I do not believe that, and I feel that it is a failure for both the revascularization therapy and medical therapy in the 21st century. 20% likelihood of having an event over the 5 years, is that something which is acceptable in today's day and age? But here came the FAME family of studies. And as you saw in the FAME 2, that when those subjects who were significantly ischemic, that is, who demonstrated the FFR of less than 0.8, and if are randomized to receive either optimal medical therapy or revascularization, they demonstrated that the outcomes were significantly superior with revascularization. What does that mean? Did we really need ischemia producing lesions to succeed with revascularization? We started to feel so, and we started to include that in our guidelines. And then came ischemia. And that showed us that at least it was not so when we are considering the functionally severe ischemia. These people had the functionally evidence of severe ischemia, be it by the nuclear scans or be it by the echocardiography. However, when you look at the same time of follow-up, there was essentially no difference in the optimal medical therapy or conservatively managed arm and the invasive arm. So, where do we go wrong? Did ischemia reveal something more than what we have so far thought? So the most important thing here is that if you look at the two major types of myocardial infarction, and that was their subsequent paper that came in circulation, and you would see here that the procedural MI, that is the type 4A or 5, you saw that that was significantly higher in the invasive arm, as obviously you would expect. And that was equal to something what we see as the spontaneous myocardial infarction, which occurred significantly more in the conservative arm as compared to the invasive arm, leading to a trial which was essentially became a negative trial. However, if I focus on the spontaneous MI rate, in the conservative arm, it was 5.8%. In the invasive arm, it was 2.8%, with an absolute difference or relative risk, absolute risk reduction of 3% and relative risk reduction of more than 50%. So, did ischemia demonstrate failure of revascularization to reduce myocardial infarction, or failure of ischemia testing to guide revascularization? Or does it mean that we were missing something more than that? However, when you return back to the FAME 2, and then came the 5-year follow-up of FAME 2, and that showed that PCI is superior to OMT for FFR positive lesions, but in the optimally medically managed arm, however, there was no difference in the major events, and predominant difference was seen in revascularization. But yet, 50% of the people who were managed medically did not have any event, did not need revascularization, and had similar relief from angina as would the revascularization have, creating a question that all ischemic lesions may not require revascularization. So how can we identify FFR positive lesions that are safe to defer to OMT? Here came a post hoc study of theirs, which came from Habib Samadi's group. And what did he do was that he, in a very elegant design, looked at the optimal medical therapy group and looked at those coronary angiograms which were associated with the outcomes which were adverse versus those which were favorable, and demonstrated, just looking at coronary arteriograms, creating the 3D reconstructions and using the wall shear stress, demonstrated that only about half of them had the high wall shear stress. And whenever the high wall shear stress was present, it resulted in much worse outcome as those where it was not high wall shear stress. It should have been less than 4.71 PA. So in significantly ischemic lesions, lack of plaque vulnerability and high wall shear stress represents the plaque vulnerability, probably predicts safe deferral even after the FFR has been abnormal. So let's put it all together and see whether we can come up with a better algorithm for indication for revascularization. So what was the past? What is the present? And what should be the future? So the past was that 100% of anatomically significant lesions be revascularized, as we saw in the European case study. Currently, we think that we should take away the non-FFR abnormal lesions and take a bite out here, which is about 33% of lesions. But 66% yet require revascularization. What should be the future? The future should be that if I'm able to identify the plaques which are HRP positive or high-risk plaque positive, as was shown by Habib Samadi's group, or as we have found with the CT angiography, we should be able to further cut this into half and leave only about 33% of lesions which may benefit from revascularization. The rest of the subjects can be treated with the optimal medical therapy. And that is something what we have started to now demonstrate in our CT angiography studies. As you can see here, that this is a CT angiogram, and here you can see a positively remodeled lesion. You can clearly see there is a positive remodeling, or the vessel wall is coming out on both the sides. And also that there is a huge necrotic core here, which is shown here by the low density or the low attenuation plaque here. And we called it two feature positive plaques. One feature was positive remodeling, and another feature was the large necrotic core. And then not only that, there was the larger the necrotic core, earlier was the event, and greater was the likelihood of an event. So high-risk lesions can be non-invasively recognized, and morphology determines likelihood as well as the time to event. There was 45 times higher likelihood of having an event over the next 2 years, and we had followed 1,000 people for 2 years to get to these results. We have further demonstrated recently that now we can identify these features by the automated manner, because that was one problem that was not being solved. And using the machine learning, we have identified that there are 6 features, not just the 2 features, which are important, be it at vessel level or be it at the risk factor levels. And there is a significant increase in likelihood of having an event. And not only that, most important thing is that if I look at the 70% diameter stenosis, you'll see that we are literally almost at a line of equity here, that if I did the intervention, the outcomes are not going to be great. On the other hand, if I add the FFR, there is an improvement in the ROC. But if I use the morphology, there is a significantly bigger improvement here and a slightly more improvement if I use the FFR also, as well as the morphological assessment. So automated and quantitative assessment of the plaque morphology is possible. And once you identify those lesions, can you really go and treat them invasively? And this was the Prospect 2 study where they demonstrated. However, in this particular study, only those lesions were taken which were normal FFR and not abnormal FFR. So even though they used that, the difference obviously was not statistically significant, but they did demonstrate that there was a superior outcome, although statistically insignificant. There was a statistically insignificant, but otherwise it's superior outcome in terms of those who had received a stent in the plaques, which were highly vulnerable, as demonstrated by intravascular ultrasound. And the identification was based on the presence of more than 70% plaque burden. Now, in our larger study, in which we used 3,000 subjects, recruited 3,000 subjects and followed them for up to 10 years' time, and the endpoint was again the major adverse cardiac events, we saw that there was 10-fold higher likelihood of having an event with the high-risk plaques as compared to those which were non-high-risk plaques. And as you can see here, up to 2 years, there was essentially no event that was occurring, as I had shown you in my earlier study. And not only that, when the plaques started to become much larger, if you remember that once we reach the Glagovian limit, we really start to impinge on the lumen significantly. So if there was a significant stenosis in association with the high-risk plaque, the likelihood was significantly higher. In about 500 subjects, we had 2 CT scans spread one year apart. And we demonstrated that those lesions which demonstrated significantly higher plaque progression, that is, their necrotic core size increased, there was 35-fold higher likelihood of having an event over time. On the other hand, the plaques which were high-risk plaques, but they did not progress in the interval, these were the subjects who did not develop an event, almost telling us that the plaque progression is a prelude to the spontaneous myocardial infarction. And then we started looking at the data that are available, although there has been a feeling that these lesions are flimsy lesions. These are minimally occlusive lesions. And multiple important investigators have said that over and over, that if we have an event, but if we have a previous coronary angiogram available to us, the luminal obstruction was not significant, and it became almost a myth in cardiology. And it has been ingrained in our mind so significantly that the lesions, which are small lesions, they are likely to result in acute events. And these are not the stenotic lesions which result in an event. However, when you look at those when the event has already occurred, or even in the autopsies as shown here in this bar, these lesions are 70% or higher stenotic lesions. So where is the missing link? The missing link is that the studies which demonstrated 30% or so luminal occlusion, they were far removed from the time of acute event. And those which were done within about 3 months' time of the acute event, they had demonstrated 70% or more lesions, as seen here. And those where there were, by chance, 2 coronary angiograms available, for example, here in purple to purple bar, or in blue to blue bar, you would see, or black to black bar, you will see that there is a significant progression of the lesion over the period of time before actually the event has occurred. So here you would see in the schematic illustration that there is a progression of the plaque as the decades go by. Here you can see the 10, 20, 30, third, fourth, fifth decade. And then you would see that there comes a time when there is a rapid progression once the positive remodeling stops, and then the luminal obstruction starts to occur, something which is now much more amenable to the hemodynamic instability. So question here is that should we really be changing our definitions of primary and secondary prevention? Should primary prevention be before the actual atherosclerosis has started? Should I really bring in the imaging technology so as to help us identify the disease when it indeed starts to occur? But more important than that, what I really want to show you here is that this is the collage of multiple studies here, those which have been done by the coronary angiography in response to the lipid lowering therapy, and those which have been used where the intravascular ultrasound has been used. It demonstrates to us that the plaque progression stops if we are at about 70 milligram LDL level. However, if we go even lower, the possibility is that the plaque regression may occur. So plaque progression, although was a prelude to an event, it is modifiable. It is a necessary step, but it is a modifiable step. And the lipid lowering therapy halts the progression. And that is what we have shown now in the patients. So now, as we move from the plaques to the patients, here you would see the CT angiograms where we have demonstrated that after 9 months of the consumption of statins, one is able to significantly reduce the plaque volume, and that was essentially the low attenuation plaque volume or necrotic core volume that is reduced. Not only that, the plaque is changed, the cardiovascular events change. For example, this is the primary prevention, again in various studies, and here the secondary prevention studies. And if we really put them on a scale here and start to draw an imaginary line, if you want to prevent an event in secondary prevention, or if you want that there should be no event that should occur after once the event has occurred, you will have to bring down the LDL level down to about 30 or 35 milligram percent. On the other hand, if you want to have a primary prevention, you'll have to bring yourself down to about 50 milligram percent. So hence, LLT helps significantly reduce MACE. Now, here is a patient of ours. He is a CEO of a big company. Father had a heart attack in his 50s, and he has always been living very scared that he's also going to have it. He's 72 years old, does everything right in his life. And here you see his CT angiogram. The FFR is abnormal. If you look at the CT angiogram, there is a huge lipid core. There is a not very thin, but there is a thin fibrous cap. And when we gave him the maximal dosage of statins and ezetimibe and followed him 6 months later, you'll see that the necrotic core has almost disappeared. There is a thickness of the fibrous cap that you can see, and even the FFR has become normal. And we can later on discuss as to why the FFR may become normal, while we always think that it tells us about the luminal stenosis. Can we bring down the lipid levels to a desirable level as we think? Yes, now we have PCSK9 inhibitors that can even further reduce when given over and above the maximal dosage of statins. And as you can see here, 75% of the subjects have FFR, have the LDL levels, which are between 25 to 75. About 15% are those which have less than 25, and about 10% are those which have the LDL levels of even less than 15 milligram percent. Not only that, it also increases the fibrous cap thickness, as was shown by the hyphen study by Steve Nichols in the European study of cardiology, where the subjects received every 2 weeks the PCSK9 inhibitor. So the latest guidelines of the European Society of Cardiology, they even have become bolder. They want us to have less than 70, less than 55, and less than 40. I think they are still too high. They really need to come down further. But how many people really are able to do that? And as you would see here, that the latest guidelines, there are only about 18% of the people, 1 in 5, who is able to reach the true goal. And this is the Da Vinci study from Dr. Kosik Ray's group. And as you can see here, that if you do not reach the levels that you want, and if you are not adherent, there is statins are giving you a 5% benefit. And if you are adherent or you are compliant with the treatment and you are on a high intensity statin, the reduction could be up to 60%. So even though the statins are extremely effective, the compliance with the lipid lowering therapy is dismal. The newer techniques, as you will see, the RNA-based approaches, be it the antisense or be it the small inhibitors of the RNA, we are getting closer to vaccination here, because that is to be given every 6 months, and you are able to reduce the levels by about 55%. So can you really think out of box here? And this is again the study by Dr. Kosik Ray, which which has just been started in England by the NHS. And this is something that you have to think really out of the box. The possibility is that if you start giving the inclisiran or the mRNA every 6 months, the mRNA inhibitors every 6 months, and if you look at the Mendelian randomization median follow-up of 50 years, you'll be able to reduce the likelihood of an event by up to about 80%. So this is an unusual type of an approach, but 300,000 subjects are going to be treated in England who have the high likelihood of risk, and it is expected that there will be a significant reduction in the mortality over 4 to 5 years. So if I take a community, and this is just to end the talk now, that if we take a community where the PCSK9 is low because of the loss of function, you can clearly see that not only that the LDL is significantly lower, it is about 60% lower. The coronary artery disease is lower, or the events because of coronary artery disease is significantly lower, coming to about 50%. And also the strokes are significantly lower. And if I go there and look at the LDL and we query ourselves, what was the LDL what God gave us? And here is one of the papers which just came out. In this, I'm fortunate that I did it with the editor-in-chief of Circulation and editor-in-chief at that time of European Heart Journal, Tom Lucier and Joe Hill. And we demonstrated that as the literature shows, that we are born with 25 mg% of LDL. And within about 3 years' time to 5 years' time, the levels reach 130 to 150 milligrams of LDL. What do we do to our children? Not only ourselves, let's look at the animals. And what do you find? That most of the animals have less than 100 total cholesterol. There is only one animal in this world who is proud of 200 cholesterol, and that is human. And not only that, this 100 cholesterol is essentially made up of HDL, not of LDL. Look at all the electrophoretic patterns of all the animals here except a pig. Every single one of them has high HDL levels and very low LDL levels. There are only 2 animals here, human and pig, where you see significantly higher LDL levels. But again, LDL levels do not reach the level what happens in human. Why is it so? What are we doing to ourselves? And that's what Dr. Braunwald just proposed, that if we improve our lifestyles, we basically would be able, and we bring down the LDL cholesterol. And if this is the threshold, which is there for the atherosclerotic cardiovascular disease, you will be able to double your age here. So the age will go from 30 to almost 60 years, or 35 to 70 years. But somewhere here, if I started to reduce the LDL further, and for example, started inclisiran every 6 months, we basically should be able to live to 100. So he says how to live to 100 before developing clinically coronary artery disease, and he called it a suggestion. And does it really happen, or can it really happen? And here are some of our studies in Amazonian jungles. We went and looked at it at the Chimane tribe. This is a octogenarian woman. This is a 90 years old, a 99 years old woman with an 85 years old husband. These are the people who walk the whole day. They don't smoke. They live without pollution. They eat once a day. And what do they eat? Pig, jaguar, monkey, and plantains and papayas. They just create a stew and only eat once a day. So those tribes, they do know how to live better than us. Their LDLs have always been, lifetime LDLs have been less than 70. Their systolic pressure has been less than 115. Their blood sugar has been less than 80. And their BMI has been less than 25. They walk at least 15,000 steps a day, if not more. There is no air pollution. We did 700 CT scans in them to look at the coronary artery calcium, and we have 3,500 carotid ultrasounds in them. So they do not develop. Their coronary artery calcium scores are the lowest for any human race known. So when we published that paper in Lancet, there were 2 days back-to-back coverage in New York Times, Heart Healthy in Amazon, and learning from our parents' heart health mistakes. So, ladies and gentlemen, if this was the real natural history, can we wipe our sins? Thank you. Parthoji, you are on mute.
Thank you very much, Dr. Narula, for the wonderful presentation. And I've seen a few versions of this previously, and it gets better and better each time I see, and it becomes more and more practical. I think we can go ahead and bring everyone on the panel. So if Joseph, you can bring Dr. Narula, myself, Dr. Singhal, and Tudor on a panel. We can start with some questions. And the first question that I was proposing, Dr. Narula, is you showed us elegant studies from CT, and you can perhaps provide a more in-depth information about the coronary vasculature now from CT. Where do you see the field moving? Right now, I can tell you in New Jersey, it's fairly coronary invasive angiogram, and the conventional stress tests pattern of culture for looking at coronary artery disease. And how do we get away from this big pre-authorization issue, which leads us to inability to get testing done? What should big health system aim for?
Parthoji, it's a very loaded question. And essentially, there is no simple answer to that. First of all, we really need better guidelines. And I do know that the change is expected in the guidelines. Europeans have already done it. We are going to do it. That CT angiography would become, should become, I don't know whether it would, but it should become class 1 indication for the assessment of our patients. Insurance companies need to recognize and understand that not only that it gives me more information and better information, it is significantly much cheaper as compared to the other imaging modalities. The CMS reimbursement of CT angiography is probably half of the echoes and stress echoes, and probably a third or a fourth of the nuclear imaging. So one would see an increasing use of it, as the time goes by. However, there are certain important limitations of the CT angiography also, which we may have to look into. So probably the way we are going to eventually settle would be something what has been shown by the NICE guidelines, the National Institute of Clinical Excellence in the UK, that if you have an unknown status, that is that you do not know that you have coronary artery disease or not, probably the whether symptomatic, asymptomatic, high risk, you will probably go with the CT angiogram. And if you know that you have the disease and previously it has been established, probably it will be something to compare. It will be dependent upon the more likely on the nuclear or the PET scans. As we now know, because of the oncology, the prevalence of the PET scans is also increasing. We will be able to even identify the quantitative flow to the epicardium, endocardium, territories, whatever else we want to look at. We would be able to get the exact values of there. So I think the time is coming when we would be seeing more use of it. The major problem with the CT angiography otherwise has been that there has not been a quantitative way of looking at the necrotic core and positive remodeling and all those things. And all these studies that we have shown, 1 feature positive, 2 feature positive, 3 feature positive, whatever it is, it was all a qualitative phenomenon. And so we need to go beyond that. We need to go further than that. And now that the automated ways are coming, we should be able to do that. We also should be able to identify FFR by CT angiography. And we also should be able to look at the flow in terms of the mass of the myocardium as to what are the FFR versus the myocardium in terms of the actual supply and demand ratios there. So CT definitely is going to be the technique. And I think the time has come where we should be realizing as to what technique is the best for which situation, rather than me claiming that my echo is the best and somebody else saying my nuclear is the best. And I always clamor that my CT angiography is the best. And then somebody else comes in and says that, oh, you know what, my magnetic resonance is one-stop shop. So it is not a question of one-stop shop or 2 stops or whatever else it is. We really need to know which patient deserves what and where I get the best information. So, I mean, I think that was a long-winded answer to your
Yes. No, I think
question.
Yeah, no, I think the reason I would give you an understanding about here, I mean, we are still, not embrace CT as much, and we are trying to make some specific effort. In fact, we are trying to get in our new academic center. We're going to have more emphasis on CT coronary angiogram, and we'll really look forward to collaborating perhaps on some of these opportunities. And I would like to ask Dinesh a question. And Dr. Narula pointed out the need for, as he was mentioning towards the end of his comments just now, individualized medicine. And I think there is I see in your practice in Metabolic Heart Institute, you have been very entrepreneurial. Can you just give an understanding of how much individualized prescription typically you follow and what are the challenges in New Jersey?
So yeah, Dr. Narula, this was a very elegant presentation, and it was a wonderful synopsis of where we are. And I'll kind of answer this with putting some of your points together. So you obviously shown that lower the LDL, the better off we are. We also have these populations where we have octogenarians, whether it's Okinawa population in Amazon, which show that a better lifestyle can actually, you can live with that lower LDL. We have these newer technologies which are accessible to us within certain limitations, but they come at a cost. We're kind of living in this era where value-based care and a cost-conscious way of practicing medicine is a critical piece. The resources are finite. And the challenge we face in real life practice when patients come to us, I kind of find 2 or 3 challenges we have. Number one, we know all this. We know that a lower LDL is good, that certain lifestyle components are good. How do we create an ecosystem where the individual patient or the individual client changes their lifestyle? And for those who come to us, sometimes with an event and sometimes looking for help from a primary end standpoint, to have them change the things which they need to change in their lifestyle, so we can keep the cost of our investigations low and get them to adopt the tools which are needed. That is a big challenge. And one of the things I've found is there's usually some either an event or some recognition of some pre-existing plaque, whether it's a coronary calcium score, whether they turn diabetic, some event which kind of motivates more than the others. But then when you have to give them the professional help to change that lifestyle, and you need the dietitian in the mix, or the exercise person in the mix, or the motivational behavioral therapist in the mix, the patient's not willing to step up and kind of pay for that expense. The payer in that ecosystem is not willing to spend because it's all preventive care. And a lot of the physicians, like us, because the economics are not there, are not willing to step up and help that person. So the challenge we face is really the economics of this whole wellness piece, which needs to come in, and that's kind of where the biggest challenge is, where patients not willing to pay, the payer is not willing to pay, the self-insured employer is not willing to pay. A few years ago, we started an intensive cardiac rehab program in our practice. Work Dean Ornish has done, people like Pritikin have done, and patients who are able to take part in it, where the system is paying, do phenomenally well. Their lipid numbers go down even with no additional increase in medicines. I've had patients with their LDLs drop way low, but to get the insurances to pay for it, so Medicare recognizes it. You go to the Horizon of this world because they're looking at it short term. They're not willing to step up because this patient's not going to be with them for a long time. So the biggest challenge is to figure out an ecosystem where everybody is focused on this wellness, realizes what Dr. Narula just said, where the LDLs have to be lower, correlate with some kind of simple test out there, and support the individual, because that's kind of so the economics of this whole wellness piece and lowering LDL without a lot of testing is where the challenge is for us.
And I think this probably is a challenge everywhere, but I guess this is where our opportunity, particularly when health systems and institutions, and including our ability to engage with our payers, insurance companies, I think somebody will have to take a bigger role in trying to promote the wellness. And I agree that challenge is there. And I'm also wondering, it's not just about motivation, it's the compliance and the psychology aspect of the behavioral therapy. I mean, how many of our cardiology patients go for any form of behavioral therapies? I don't think we look at that angle. So there is probably a bigger need. Events are happening, and then, of course, I think there's much more opportunity for patients and being more compliant. But I agree with you. Jagachi, any reaction to that? What you guys
I fully agree, Parthuji. I absolutely agree with Dineshji that it is our system which needs to be changed. And so one important thing is that we will have to invest in education of the people, specifically children. And in that article that I had shown with Joe Hill and Tom Lucier, we have gone on to the extent of saying that it starts at the infancy, not even in the children. So we basically, because later on it might be way too late once the PCSK9 levels in your body have increased significantly. And we have demonstrated that how you correlate them with the formula. And so essentially, the education has to be there. The payers have to recognize, and that's exactly what Dinesh just said, that if you look at CMS, they understand it because they have eventually to pay. And the other group which really understands this is the Kaiser system, because people live with them for all their lives. Otherwise, it is all temporary phenomenon. And I was talking to Dr. Braunwald the other day, and I had asked him, I said, what system do you think would work the best? And he said, Kaiser. The reason is that you are headed towards the preventive care. You are headed towards the population health rather than focusing on a patient. I mean, what is happening is that our mortalities are coming down, but proportionately, the cost is increasing. We basically need to decrease the cost and improve the health. Why are we the country with the worst health, with the maximum expenditure in the top 11 countries, top 11 income countries in the world? So we do not understand exactly, as Dinesh just said, that we do not understand the economic of the disease. Or is it that these economics work better for somebody else and not for the recipient?
Yeah.
I'll tell you one very simple thing. It was today only that I was in the CCU in the morning, and there is a patient with the BMI of 70.
Mm-hmm.
And he is a PhD student in health sciences. Now, it is not, I can't villainize him for what is happening. The criminalization is occurring at the level of the industry. We do understand that. The man cannot have food. He's just trying to scrape through so that he is able to do his studies and is able to get to the level where he could start earning for himself. He feeds his entire family of his elders and brothers and sisters. What he gets best is a burger of $1, which everybody eats through the day. You know, and we villainize these people. Oh, you know what? You don't understand. You are hurting yourself. He's not hurting himself. I was talking to him and he says that one bowl of, and he's somewhere here, and he says, I go to this shop, which I go to also, and I have my salad every day there. He says that one bowl of salad is $15. And we villainize the patient only. So Dinesh is absolutely right when he says that it all boils down to economic. And unless we all get together and get into it properly and deal with the system, we are not going to be able to help this problem, at least in this country.
Yeah, social determinants of health are equally important.
Absolutely.
Yes. So Tudor, you heard from Dr. Narula. What do you do in your cath lab to prevent an oculostenotic reflex from your team? Because I know that it's often challenging to have a lesion on the table. The patient is undergoing a coronary angiogram, and you know, story is a story, history is a history. I know that FFR is probably being done, but do you think you will be able to come to a practice where you can leave a lesion and try a medical therapy like we did in the trials, or is not a reality at all?
I think that it's a patient-driven factor, because we usually treat the patient as per the symptoms that trigger the presentation. This lab is a little bit different because we are a referral center. So patients get studies in an outside hospital. They are coming here for the procedure 90% of the time. But I think we had patients where the clinical history was as such that we do also very liberal intravascular imaging. We do very, very high percentage of intravascular ultrasound, so we can appreciate the remodeling very, very fast. And also if the plaques are stable or not. But the idea to leave a plaque that is not critical, a lesion that's not critical, unstented, and to emphasize medical management is on the market since many years. It was actually pioneered by the Zvole group in the heart attack patients, but I don't think in the United States that's feasible, because if you don't stent acute coronary syndrome, that becomes a major issue after that. I would rather say that the most important thing is moving from this focused care on the particular patient and nailing down to the plaque, to the populational aspect, because if you emphasize healthy lifestyle changes from the get-go, then you decrease automatically the amount of patients that come to the lab. And I will just ask Dr. Narula to mention a little bit, as long as he can, emphasize his program that's so successful outside the United States, the HAPPY program that he pioneered in different parts of the world. And that's a great program to go into the community and to increase the awareness of the disease, as well as to educate them to decrease the impact of risk factors for cardiovascular diseases.
So Tudor, I did not get the question right. So
you started these programs to influence communities into this program called HAPPY.
Mm-hmm.
That you started in Europe, then you moved to India, and I think that's extremely powerful to send a message out in the community about the risk of cardiovascular diseases and to decrease, by influencing risk factors, the events in this population. And I think if this would be doable in the United States, that would be fantastic to move into the longitudinal aspect of delivering care.
But Tudor, it's a great question, actually. And in India, we had done it with Parthogy only, the HAPPY part. But we actually started it in Irvine. And Partho would remember that actually the origin was in HAPPY, where the HAPPY origin was something we were not able to do anything up there. Although the way we started working on it was trying and doing the CT angiography, because we had a very special situation that we had gotten a gift of a CT scanner from Toshiba. That was the first 64 slicer that had come to United States, and Toshiba was in our backyard in UC Irvine. And so they gave it to us, and they wanted us to kind of identify the plaque vulnerability by CT angiography. And it was a $5 million gift, including the machine and the setup that they did, and as they paid for it and all. So basically, we were hoping that we will be able to do that. And but as Dinesh just said, that it becomes extremely difficult here. On the other hand, in Europe, it has been extremely successful. Netherlands, in England, and other places. You know, like, I mean, we have all these events that we organize, and we like the 10K runs. On one side, we collect their blood, we do their blood pressure, we do their small little questionnaire, and then they go for the 10K run. And when they come out on the other side, their glucose, cholesterol, and all have been done, and you have gotten their risk factor profiles there. And then you demonstrate to them that this is good, that what they are doing, 50% of people or more who are doing well continue to do their lifestyle. And we continue to send them the emails and all with the healthy life and all those things, advisories. Then there are some of the intermediate group of people where we want them to come over for the calcium scans or carotid ultrasounds and things like that, which is all paid for in those countries. And finally, there are high-risk people where we take them up for some advanced imaging studies and things like that. So it is way easier in those countries where the doctors are able to influence the system significantly more than what we can do. Now, would that be a possibility? I'm hoping that someday it will be, and there would be better days that will dawn on our healthcare. Probably, yes.
So, you know, I think we are way over the time, the hour. So I want to thank everyone, but I wanted to tell everyone also that Dr. Narula loves to see movies. And if he has not seen the recent James Bond movie, No Time to Die, maybe that there's an approach there. So they design nanobots that can travel into population and can go to specific genetic machinery and make a change. So perhaps something like that. I mean, if messenger RNAs and studies like this are coming, maybe in the future, somehow we could alter the genetic machinery and make the population, at least the vulnerable ones. I was thinking about that. This idea just came right now.
Let me tell you one thing. I love the way your passion is this. I know that. But I tell you that don't expect the science to change everything. We can very easily change ourselves. It is just a lifestyle change. It is not that I've got to be eating 5,000 calories in a day and then I expect the science to be able to knock out or come up with some GLP-1 enhancing genetic changes and things like that. I think I would still differ there. And I would say that we need to fix ourselves. We need to educate our people. We need to learn what is going on. We need to not be manipulated by the industry and by the system. And we need to look after ourselves. Why is it that after having a heart attack, half of us are able to change our lifestyle and we don't do it before having a heart attack? Why do we have to have a slap first before we recover? So I think I will go a step before that. Yes, nanobots may be a great idea for those who have gotten the disease. But before that, I think we have to prevent them from getting there. Exactly one sentence that Tudor said was amazing when he said that when we fix ourselves, we probably will be seeing less of those patients. There was that sentence was very gravid sentence, which he said. And he said it very softly, which we did not pick up.
Very good, very good. So I think, thank you very much for a great discussion. I really thank Dr. Narula, Dinesh, and Tudor for joining. I think this has been a wonderful discussion. It will be available on the YouTube for people to view it again. And once again, I would provide the emails, and there is also, Joseph is providing all the steps for getting the CME credits and MOC credits. So please go ahead and if you are going to avail of any of those opportunities, that will be available for the next 12 hours. Thank you very much, everyone, and a good evening to all of you.
Thank you.
Thanks.
Thank you.